I think we can start 9 o'clock.
Senão eles não te veem aqui, ó.
Good morning, everyone. Thank you all for joining today's session dedicated to CSF-Venous Fistula. It's a great pleasure and honor to welcome the Neurointerventional Radiology team from Lahey Hospital, who will be leading today's presentations. We're privileged to have three outstanding experts with us, Dr. Timo Krings, Dr. Patel, and Dr. Emanuele Orru. We will start with Dr. Krings presenting the lecture Introduction of SIH, Clinical Findings and the Putative Role of the Glymphatic System. Dr. Krings studied medicine in Aachen, Germany, and Harvard Medical School in Boston. He completed neuroradiology residency in Aachen and fellowship with Professor Pierre Lajunière in Paris. He later served as a professor and chief of radiology at the University of Toronto. Currently, he's director of the Neurointerventional Radiology Department at Lahey Hospital and professor of radiology at UMass Chain, Lahey. So please, Dr. Krings, you can start.
Thank you very much, Dr. Fetosa, and thank you very much for organizing this timely conference on SIH, spontaneous intracranial hypotension. We will have the entire team today presenting with Dr. Patel and Dr. Orru. I will give a brief introduction on what SIH is, and then Dr. Patel will speak about the diagnostics and Dr. Orru about the therapeutic aspects of it. There are no relevant disclosures in relation to this presentation. Some few words about Lahey. Lahey is located in the north of Boston. It's been very well known with my predecessors, Dr. Insup Choi and Dr. A.J. Vaklu. This is our dedicated team. We are only doing neurointervention. We have 2 angio suites, 4 physicians, Dr. Orru, Dr. Patel, here, Dr. Pace, and me, and like a great team of technologists and nurses. And we were extremely happy to have Dr. Fetosa with us for like 1 month here in Lahey as an observer. And it was definitely great having him with us. Now, I will speak about like a little bit about the introduction on SIH, clinical findings, and about the glymphatic system. So what is SIH? When I was in med school, this disease didn't exist yet, although obviously patients were afflicted with it. But it is a relatively newly defined entity that is characterized by classically headaches that are worse in an upright position and that can be alleviated if the patient is in the recumbent or prone position. It is believed to be related to a loss of CSF, which then leads to a downward displacement of the intracranial structures, the classical brain sagging. It can cause significant morbidity and long-term disability. And sometimes, in rare cases, even present with life-threatening symptoms such as coma and decreased consciousness. And as I said, the knowledge has significantly increased over the past decade. It is believed to be present as common as a subarachnoid hemorrhage. So 5 in 100,000 persons per year will be diagnosed with spontaneous intracranial hypotension. However, it is really important to realize that the incidence is very likely higher because there's now a growing recognition, but many like physicians don't know this disease yet. And this is also highlighted by the fact that the first diagnosis in patients with SIH is very commonly incorrect, and patients are labeled as having migraines or psychological issues. Women are more commonly affected than men, and it can be present in all age groups, although it is most common in middle-aged women, like between 20 to 40, 50 years of age. When we are talking about SIH, we'll have to understand a little bit about CSF physiology. And here we'll need to think about the CSF not only in the classical Monroe-Kelly doctrine, but in the more modern notion of the interplay between CSF, the perivascular spaces, the interstitial fluid, and the lymphatic system. And we will discuss about this glymphatic model a little bit later in greater detail. Just very briefly regarding the CSF physiology, in the prone position, there's an equal pressure of the cerebrospinal fluid along the craniospinal axis. However, if you're getting into an upright position, there's a mildly negative intracranial and a positive intraspinal pressure. The zero pressure point is somewhere around the upper cervical spine. That's the hydrostatic indifference point. And this HIP changes when you're coming from a recumbent to an upright position. And if
Timo, I think your
Yeah,
connection has glitched. Can you still hear us?
I think the connection is lost with Dr. Timo
in the
Krings.
suprachiasmatic space and the ventricles,
And
and is the interstitial fluid that is kind of bathing the neural tissue that is present within the neuropil, i.e., inside the brain tissue. And this interstitial fluid is of importance because it's not static, it's actually moving, and the movement is directional. The directional movement or the convective flow of the interstitial fluid is governed by the arterial pulsations that will lead as a pumping mechanism to an extraction of water from the perivascular arterial spaces into the perivascular venous spaces. And while this water is flowing through the neuropil, through the brain parenchyma, it is actually transporting waste products such as amyloid uh, uh, from the brain tissue into the perivascular spaces, and from there into the lymphatic and perivenous spaces. And this has been marked as the so-called garbage truck of the brain, i.e., a waste removal process that is governed by the interplay of perivascular spaces, subarachnoid spaces, CSF, ISF, and the perivenular spaces. The way that these cerebral hydrodynamics work is, as I said, through a pumping mechanism. And this can be best explained by having here a transectional view of an artery or an arteriole that is entering into the brain. We have a periarterial, perivascular space. We have the arterial wall here and the astrocyte end feet around this perivascular space. And now with every single cardiac cycle, this blood vessel pulsates, whereas the venules don't have like a smooth muscle wall, and therefore do not have the same pulsatility. And therefore there's a directional flow of this pumping mechanism of the water in the perivascular spaces, i.e. of the cerebrospinal fluid, into the interstitium. Now, things can go wrong with cerebral hydrodynamics, and this is like a paper that we recently published with Professor Key from Singapore, where we were discussing about what can go wrong with the glymphatic system and this convective flow. And many things can go wrong, but what we will discuss today about is only the intracranial hypotension. Because when you have intracranial hypotension, then your CSF spaces will be collapsed, And this collapse of the CSF spaces will lead to decreased pulsatility, decreased CSF volume, therefore leading to decreased CSF inflow into the interstitium. And this can explain why we have often patients who present with intracranial hypotension with kind of unspecific symptoms, such as brain fog or not being completely there, because there's less waste products now being resolved due to the decreased CSF volume, which will lead to decreased CSF inflow into the interstitium. And this was published in a couple of papers and also shown to actually be possible to be improved after treatment of these CSF leaks. So the low intracranial pressure diminishes the pressure gradient, weakens the driving force for CSF to enter the interstitium, and it may even cause the perivascular spaces to narrow or collapse due to decreased transmural pressure. So, what are the clinical findings of patients with SIH? The CSF loss can lead to multiple findings. The sagging of the brain can lead to traction on the meninges and therefore to headache. This is the most common symptoms. The downward traction can cause shearing of bridging veins, and patients can present with bilateral spontaneous subdural hematomas that, of course, should not be embolized now, but where we should actually think about the cause of this subdural hematoma being the decreased CSF pressure. Traction on cranial nerves can lead to diplopia, but also some form of tinnitus or other vestibulocochlear disturbances, vertigo, pulse, non-pulse synchronous tinnitus. The glymphatic alterations can lead to a symptom of like that is similar to frontotemporal dementia. And if the brain sagging is really severe, it will lead to coma. When the patient changes his position from the upright into a prone position, these symptoms classically are relieved. And what is interesting is that for each patient, the timing in between, like getting into the prone position, getting into the upright position, uh, as compared to when the symptoms begin, are always pretty much the same. So for some patients, it may be 20 minutes. For some patients, it may be an hour or 2 hours. But within a single patient, it is often the same. Symptoms can be alleviated by anything that increases the pressure intracranial. So caffeine often can help, and even bending of your stomach can help. There are different types of CSF leaks. You can leak your CSF into the epidural space, either anterior, then you will have a spinal longitudinal epidural collection or SLAC, and Dr. Patel will speak more about this. You can have a lateral epidural leak. You can have a leak into the nerve root diverticula, or you can have a direct CSF to venous fistula. Today, we will mainly speak regarding the management about these types. And then there's the obscure internal CSF leak, where we can't really identify where the leak is present, but the patients do still have symptoms of intracranial hypotension. Here are a couple of examples that demonstrate the previously thought to be most common type, the bony spicula that can tear through the dura, that will then lead to leakage of CSF into the ventral epidural space. And on surgical inspection, you can often see this type of leak here. And this can be treated well with the surgical reconstruction of the dura. Less common are the lateral leaks, where the leakage is here more lateral and closer to the nerve root, and where you don't have a spinal longitudinal epidural collection that is ventral, but that is more common laterally located here. And these two types are, as Dr. Patel will also discuss, best diagnosed with CT myelography. Type 2 leaks are related to the diverticulum, where you can see that you have a leakage going towards the diverticulum, and there's just like a leakage of CSF due to these dural ectasias or the massive diverticulum. The most common one, but under-recognized one, because they are not presenting with a slack, are the CSF-to-venous leaks, where the CSF is leaking into the veins. And because it's leaking into the veins, you don't see this spinal longitudinal epidural collection. And these are the ones that obviously can be treated with our endovascular means, as Dr. Orru will later explain. The internal ones or the obscure ones are like difficult to diagnose because we can't really see where the patients are losing their CSF or why they have less CSF than others, and which will cause the intracranial hypotension. Because they are often related to diverticular and connective tissue diseases, there is a relation to Marfan Ehlers-Danlos. These are patients who are at a higher risk of developing these CSF leaks. And often diverticular represent this structural weakness that will lead to CSF egressing. As I said, the most common symptoms are headaches that are worse upright, better lying down. But patients can also present with other symptoms, and these can be relatively unspecific: tinnitus, brain fog, Meniere's disease, vertigo, visual alterations, gait abnormalities, and even personality changes can be present in patients. And there are even other findings that are less common. Patients can present with bilateral subdural collections, superficial siderosis, this dementia-type symptoms, rarely with coma or even death. And sometimes the patient's symptoms are very unspecific. The differential diagnoses are mentioned here. In most cases, patients are often like misdiagnosed with one of these headache symptoms. And it's important for us as clinicians to think about this disease and to raise the awareness. And without further ado, we'll now move forward to Dr. Patel, who will speak about diagnostic approaches, how to identify patients with spontaneous intracranial hypotension.
Thank you for your great lecture, Dr. Krings. We will dedicate a time for discussion after the lectures. Now we will follow with Dr. Patel presenting the diagnosis and classification of CSF leaks. Please, Dr. Patel, feel free to start.
Yes, great. Thank you. I'm just just so I can control it, I've just popped the presentation up again. Can you guys see my screen now?
Yes.
Perfect. Okay, great. So picking up here, I think where we left off. I want to talk to you guys a little bit about the diagnostic approach. Again, as Dr. Krings mentioned, we're focusing on the diagnosis of CSF-Venous fistulae. Some of the other types of leaks will be well identified by this protocol, but we'll kind of go through it from the beginning, and I'll let you know how we approach this. I think the first thing to know is that counterintuitively, opening pressures are not that reliable, and only about a third of patients who have intracranial hypotension, symptomatic intracranial hypotension, have measurably low opening pressures. So unfortunately, you can't really exclude the disease on the basis of a normal opening pressure. And we did, for a period of time in our practice, try to measure pressures on patients to try and support or refute the diagnosis. And we didn't find that it correlated very well with whether or not they had disease that was responsive to treatment. So we've stopped doing that. If the pressure is low, i.e., less than, let's say, 6 or 8 centimeters of water, then you can be pretty sure the patient has low pressure. But if the pressure is normal, I don't think you can conclude very much. So opening pressure is not that useful. And you can imagine that if someone already has low pressure, draining off fluid in that patient is likely to exacerbate any sagging of the brain and could precipitate herniation. So these patients, it's undesirable to let off any more CSF than absolutely necessary to complete the procedures. Neuroimaging is super helpful. It is important to begin with MRI of the brain and cervical spine, complete spine, and then consider some form of myelography depending on what type of leak you're looking for. MRI brain should be the first step in all cases. And there's an acronym that kind of tells you what are the main symptoms or signs that you're looking for. Uh, they're not in order of prevalence, unfortunately. So subdural collections, which we do sometimes see, including subdural hematomas, are the S. You can have enhancement of the pachymeninges. That is really the most important finding in our experience. The veins, the venous sinuses can be engorged. The pituitary can be hyperemic, which is manifested as enlargement. And if you can see here, the pituitary in this sagittal image is very round. The upper margin of it is convex. And that, I think, is a very useful sign. And then lastly, actual sagging of the brain, which again, you see here, you see how flat the ventral pons is, sitting right up against the clivus. Sometimes on axial imaging, you'll see that the basilar artery is actually pinned between the brainstem and the clivus. That's another good sign. Occasionally, you can see descent of the tonsils below the foramen magnum, and sometimes you can see that the supratentorial brain is sitting on the base of the skull. So going through them again, here's an example on the left of pachymeningeal enhancement. This is contrast enhanced T1, not a gradient sequence, but a regular one, which generally shows no visible dura. And the fact that you can see this patient's dura diffusely enhancing here is a sign that it is thickened and engorged. On the right, you can see a comparison between the engorged and enlarged transverse sinus of a patient in low pressure versus the same patient in whom that pressure has been corrected by treatment of a leak. Here again on the far left, you can see the examples of the pons being flattened against the clivus. The optic chiasm here is sitting right on the dorsum celli. All signs of compression from sagging. Again, the cerebellar tonsils have descended just a little bit below the foramen magnum there, but you can see that the configuration is such it almost looks like a small posterior fossa in a Dandy Walker type or Chiari type malformation, but it's not. In the middle image, you can see bilateral subdural hygromas, these large collections of fluid that have developed from ex vacuo dilatation of the spaces outside the supratentorial cortex. Very occasionally, you can see slit-like ventricles from collapse of the ventricles, but I think that that is something that we have seen quite uncommonly. And to see that in the absence of other findings, such as the diffuse pachymeningeal enhancement in this patient, is uncommon. This is just a graph showing you overall the prevalence of these imaging findings. You can see that by far pachymeningeal enhancement is the most common, occurring in almost 80% of patients. Something that you don't see in this graph that I think is important again is the pituitary gland. Remember that in most post-pubertal adults, the superior margin of the pituitary gland has a concave contour. If that contour is flat, then that's a configuration that's more commonly seen in patients with low pressure than in normal patients, but can be seen in normal patients. If that superior margin of the pituitary gland is convex or rounded upward, then it is much more likely that that patient has low pressure than normal pressure. And similarly, another Other good signs here are venous sinus engorgement or even cortical vein prominence, which is a little bit difficult and subjective sometimes to assess. Prepontine cistern effacement, that's the narrowing of the prepontine cistern where the pons sits on the clivus. You can measure the distance between the mammillary bodies and the sort of anterior tip of the pons, and there is a threshold for that of about 6.5 millimeters, below which it is believed the brain is sagging and that pontomesencephalic angle is narrowing. And then, calvaire hyperostosis, that's very chronic. I don't think we've seen a lot of that. Subdural collection certainly can happen, and we have seen subdural hematomas. The key with that is you're looking for patients who have some other reason to have a subdural collection. For instance, a young patient in the absence of trauma with subdural hematomas, especially bilateral, is someone in whom I think you should suspect low pressure. There is a symptomatic or spontaneous intracranial hypotension score. This was established in Bern, Switzerland, and therefore is called the Bern score. And it is a score based upon mostly imaging findings that helps you establish a likelihood of a leak. And if the score is greater than or equal to 5, there's a high likelihood of a leak. The problem is that this score was developed for patients who have type 1 leaks, and so we're not really sure how sensitive it is for patients who have CSF venous fistula. And you can see that even up to 14% of patients with a Bern score of 0 can have, 14% of patients with CSF venous fistula can have a Bern score of 0, and many of them can have a Bern score less than 5. So it's not super reliable, but if it's high, it is certainly very helpful. The way you do the score is you give 2 points each for some of those bigger, clearer findings, such as pachymeningeal enhancement, engorgement of the venous sinuses, suprasellar cistern effacement, and I probably would give people points for that if they have enlargement of the pituitary, even if it hasn't really effaced the cistern. And then minor signs are subdural hematomas, because they're not as specific. Narrowing of the prepontine cistern, which I think is a bit subjective to evaluate, and a reduced mammaropontine distance. Those findings are the findings that you are looking for in MRI of the brain. And the reason you're looking at MRI of the brain is to see, are there signs of low pressure in the head? The reason we do MRI of the spine is to describe whether or not you can actually identify the leak or the kind of leak that it is. And in particular, we're trying to decide, is there a collection of fluid outside the thecal sac or not? And if there is a visible collection of fluid outside the thecal sac, there's a hole somewhere that needs to be identified. If there is no visible collection outside the thecal sac, but you do see nerve root sleeve diverticula, then it's either a type 2 leak where there's fluid leaking out of that just into the soft tissues and being reabsorbed, or a fistula. So it doesn't directly identify those leaks, but if you see the diverticula, then you can think that perhaps one of these occult type leaks exists. And really, as it says on the last line here, the main thing here is to decide what kind of leak you are likely to be dealing with so that you can determine next steps. Here's an example of MRI of the spine in a patient who does, in fact, have a direct leak from some sort of dural defect and has what we call a spinal longitudinal epidural collection, or SLEC. On the left, you can see an example of a collection that begins ventrally in the lower cervical spine and then spirals around the epidural sac or epidural space into the posterior epidural space here in the back. On the right, you can see an example more clearly of a ventral epidural collection, which also can come around to the back. So one important takeaway from this is that most of these SLECs are from ventral defects in the dura, but you do sometimes have fluid that dissects around to the posterior aspect of the dura as well. If you find a SLEC, then the best imaging modalities to identify where the defect are digital subtraction myelography and CT myelography. And in our practice, we typically begin with a regular CT myelogram done by the diagnostic neuroradiologists. This has the best spatial resolution, as you guys are aware. It involves the injection of intrathecal contrast. The patient is rolled to try and achieve as even a distribution of contrast as is possible, and then they're scanned. And if you were to find that the SLEC was centered, let's say on a bone spur from or an osteophyte from a disc disease, that's a pretty good sign, especially if it's a sharp, angular looking lesion, that the patient has perforation of the dura from that little piece of calcium. If CTM is unable to identify the site of a leak, then you may need to do a digital subtraction myelogram so you can actually visualize where the contrast is exiting the thecal sac. So here's an example, a schematic example on the left, showing you a calcified disc osteophyte complex that has perforated the dura and allowed cerebrospinal fluid to egress into the ventral epidural space. And on the right, you can see that under digital subtraction myelography, there's a clear beginning to where the fluid exits the thecal sac, and um, and that helps identify the site that needs to be treated by surgery. The other thing not shown in these images is it's very helpful to have high resolution bone window CT so you can see what those osteophytes look like and ensure that there is a sharp spicule of bone here that looks like it could have caused this tear. Uh, Here's an example of on the left CT myelography at the top, and the remainder of the images are MR. And these are showing on the left multiple nerve root sleeve diverticula. Remember that those can cause type 2 or type 3 leaks. The type 2 leaks will remain essentially occult, but the type 3 leaks can be somehow diagnosed by CT myelography, as I'll show you in a minute. Um, the type 2 leaks that you see on MR or on CT are the type that you see here on the right, where you actually have this sort of lobulated, irregularly marginated collection of fluid along the lateral aspect of the thecal sac, typically underneath where the nerve root comes out. And this is a pretty typical location for a visible type 2 leak. This is something that needs to be treated surgically. These are not readily amenable to any sort of durable repair by blood patching. When you are looking for lateral leaks, whether it's the CSF-Venous fistulae or those direct type 2 leaks, the best way, in our opinion, to find them is by doing lateral decubitus myelography. Different practitioners have different practices as to whether they use DSM or CTM first. In our practice, we use CTM first. And the advantages of these techniques are that you selectively check one side of the spine and you can see where contrast is leaving the thecal sac. And if it's going into a vein, you can find it as it flows into that vein typically. We'll talk a little bit more about delayed renal acquisition as we go through this, but that can also be very important for CSF venous fistulae. Positioning is kind of key for these. It's important to have the patient positioned in a lateral decubitus position. It's important, and we do these under CT, so I'm mostly going to talk about CT. It's important to have the hips elevated above the shoulders so that from L5S1 to at least the lower cervical spine, the spine is slanted downwards ever so slightly. We have found that you really want as minimal of a slant as possible, enough to allow the contrast to run down that side of the spine because it is denser than CSF, but not so much that it runs too quickly towards the head. You can see in these diagrams that they have sort of a bolster setup. We use a different kind of bolster setup where we elevate only the hips, and we find that that disrupts less the functioning of the CT table. And I think we have some pictures of that later. As I said, it needs to be done in the lateral decubitus position. It's important to find a position where the patient's going to be comfortable lying for about an hour because we do need to do imaging immediately after the contrast is injected and then delayed. If you're doing DSM in an angio suite, then you have the ability to use a tilting angio table if your system accommodates that. And that can help you control the flow rate and the level of tilt of the spine. And the other thing to know, I think, are two. Number one, practices vary as to whether they do both sides in one day or whether they do one side on one day and then wait for the contrast to clear and then bring them back. Our practice is to do them on 2 separate days. In part, we have the luxury of doing that in terms of availability of the resources. But we feel like that allows you to give the maximum amount of contrast, about 10 milliliters of contrast on each side to maximize your sensitivity of testing. It also maximizes the selectivity of delayed imaging of the kidneys, which I'll show you later on. Uh, Lastly, if you're doing DSM, because DSM is susceptible to artifacts from respiration, from cardiac motion, and so on, you have to do everything you can to minimize the movement of the patient. And in our experience, DSM is really best done under general anesthesia, which means 2 general anesthetic sessions over the course of about a week. So, DSM is something I think that has to be done very carefully if you're going to have high sensitivity. This is an example on the left of an unsubtracted image from fluoroscopic myelography, and you can see in this patient the contrast is sitting only on the right side of the thecal sac because this patient is lying with their right side down, and you can see that some of that contrast is leaking from the undersurface of the nerve root into a small slip of contrast along the lateral aspect of the thecal sac in the epidural space. This is most likely a type 2 leak. It doesn't seem to find its way into a vein. This is that same leak under CT myelography where you can see how nicely the contrast is layering in the dependent portion of the thecal sac. And then on coronal reconstructions, you can see the area where that is leaking out from the undersurface where the nerve root comes off the thecal sac into this extradural collection. A CSF-Venous fistula has a slightly different appearance. On the left, you can see the DSM or the unsubtracted myelography appearance. You can see again the contrast is layering in this case on the left side of the patient. There's a round structure here with a dashed arrow. This is the nerve root sleeve diverticulum. And all these serpentine structures around it are veins that are receiving the drainage from that diverticulum. And you can see how trace these findings are and how difficult that might be to see on myelography if this patient moves at all, especially under subtraction. On the right, you can see what this looks like at CT. This is, of course, a very good case, but you can see as we move from left to right that in all of these images, you see the diverticulum itself filling with contrast. But as time goes on, and you move to the right, you can actually see the course of the contrast leaving the diverticulum, coursing along an intersegmental vein back towards the azygous system. So this is a clear CSF-venous fistula. Unfortunately, they're not always so clear, and sometimes the findings are very subtle. This is a patient that we show frequently. She was one of our first and most impressive patients. She actually presented unresponsive, almost comatose, had to be resuscitated, admitted to the ICU. We had already done myelograms on her and were not able to identify a leak. And you can see that on a retrospective review of her images, we found in one image of one CT scan taken at a particular time point after one of her myelograms that there was one spot of contrast in this paravertebral or paraforaminal vein. And that ended up being a sign of her leak. This was repaired and she got better. So we know that it was real. So some general comments on the approach to CT myelography. The first thing to do is to get brain and spine MRI and review them to decide what kind of myelography the patient has and what kind of leak you're looking for. It's important to standardize your process because time is of the essence. You need to catch these leaks, in our belief, very early. So you need to have everything set up. You inject the contrast. You already have your CT scan of the spine set up so that when you pull the needle out, you can step out of the room and fire the CT scanner. And we generally acquire our CTs, our initial CTs, within 1 minute of the injection. Because you're going to be scrubbed, because these patients can be uncomfortable and have things like nausea or discomfort. Everyone has their role. The nurses need to know exactly what meds to give. The techs need to know how to set things up, and everything needs to run very smoothly in order to get the pictures and the timing that you need. We find it ideal to use CT fluoroscopy for the lumbar puncture. It's just a lot faster, in our view, to stand in the room and take occasional intermittent CT pictures with a foot pedal than it is to adjust the needle and step out of the room and then scan and then go back into the room. These are already potentially long procedures in terms of scanner time, and we think that CT fluoroscopy is by far the ideal way to do the punctures. And we've set up a dedicated protocol on our CT scanner in order to facilitate doing this smoothly. And patients need to be coached in advance. So as I mentioned, they're going to be lying in this position for about an hour. I always talk to them about finding a position that's comfortable where they feel like they don't need to shift around or move during the course of that hour. They need to know what they can expect to feel from local anesthetic to the injection of contrast to the side effects of that contrast reaching the internal auditory canals in the area by the brainstem, because that can cause vestibular symptoms. It can cause muffled hearing. It can cause headache, and it can cause some nausea. As I said, we do ours each side at least 72 hours apart. It is believed that 72 hours is the safe margin for ensuring that the first 10 cc's of contrast placed intrathecally have cleared from the system. We have recently started to shorten that window to 48 hours in certain cases, and it seems to be okay, but the established standard is 72. For CT myelography, we do it with very minimal sedation. We give fentanyl for pain. We give a scopolamine patch to try and limit any dizziness or motion sickness from the irritation of the vestibular system. And we give an antiemetic because of the nausea that can occur. We, in our practice, have used general anesthesia in less than 5%, maybe even less than that now, of CT myelograms. And that is certainly an advantage over DSM. And doing it all in an interventional CT scanner means you can inject the dye, you can take your pictures without moving the patient, and you can get your delayed images without moving the patient. We feel like that is the highest sensitivity, highest specificity way to do these. It's important before you get all your drapes on and everything to make sure the patient's position is correct. So it's difficult in some patients to eyeball the position of the spine. So once we get them to what we think is close, we obtain our topograms. We make sure the slant of the spine looks good, that the spine is relatively straight, and that on what is a lateral view of the patient, that the spine is not tipped too far anteroposteriorly, because that can make it difficult to get a scan of the entire spine with a small detailed field of view. I'm gonna skip ahead on some of this stuff to the last. Essentially, what we're going to do is stepwise. We're going to place the patient on the table. We will identify a skin site for puncture into the lower lumbar or even lumbosacral spine. I prefer L5S1 if the thecal sac is big enough based upon MRI, because we have seen leaks at the L5S1 level. And so I think you have to, as much as possible, look at the entire spine from sacrum to occiput. We prep the skin, we perform the puncture, we check our position by injecting a very small amount of contrast, about a half a cc to 1 cc. Then we inject about 10 cc's of saline to try and increase the pressure and provoke any sort of leakage that might be occurring. And then we give 10 cc's of contrast. We acquire, as I said, from at least L4 to the skull base. I like to go from S1 through the skull base to make sure we get everything. We have played with different reconstruction kernels, but the idea is on your scan to try and balance the amount of image noise with the ability to see small structures, because as you can see, those veins are extremely filiform, and it's important to have enough detail. But of course, as you know, the more detail you have in your CT scan, the more susceptible it is to noise. We generally perform the first acquisition as soon as the needle is out, and that one's done with a breath hold. And then we do another one with what's called forced or resistive inspiration, where we have the patient breathe in through the nozzle of a 10 cc syringe. And we do that essentially as soon as the first scan is done, usually after about 2 to 3 minutes by the time you've reset the scanner for the second scan. We keep the patient in that lateral decubitus position, and after 45 to 60 minutes, we scan the kidneys and the bladder. And the reason is that patients who have CSF venous fistulae, the contrast gets from the thecal sac to the blood earlier than it should, and that is an extremely helpful secondary sign for CSF venous fistula. So this is kind of our setup. You can see the table, the main things you need, local anesthetic. This is marked as an 18 gauge spinal needle, but I think in general we prefer now 22 gauge spinal needles. They're less traumatic, less likely to cause post-puncture headaches. Remember, these people have weak dura, and I think we have to be extremely cautious about creating a new kind of leak in them. We have experimented with the use of atraumatic needles. We find that they're difficult to steer in place, and so we have not routinely used them, but in certain high-risk patients, it's worth considering. And then this is our little manifold for injection. You can see we have a syringe that has 10 cc's of contrast at the bottom right and 10 cc's of saline. We can put a small amount of contrast into the tubing, push it with saline, do our check, and then push the rest of the saline before we inject the contrast. This is the patient setup on the table. This is actually before we formally had a foam wedge to elevate the hips. But you can see the patient position and in particular the draping. We put quite a bit of draping on. You can see Dr. Orru is contemplating his strategy for this case. And this is our setup, and this is why we like CT fluoro. You have everything in one place. You've got your patient whom we love. We have your monitors so you can see what's going on with the needle placement. We wrap the controls in sterile fashion so that you can adjust the table position as needed. And in the control room, we have the tech. We have already set up all the scans for the puncture, for the initial test injection of contrast, and for the CT myelogram so that the techs can just go in and fire what they need to fire when you're ready for them to do so. You stand immediately adjacent to the patient and place your needle into the thecal sac under fluoroscopy. And then we inject a little bit of dye. It's not shown here, but you want to make sure that when you inject a little bit of dye here, it doesn't collect in the subdural space ventrally, and that it drops down to the bottom of the thecal sac, because remember that dye is going to be heavier than CSF. And if you're lucky, you will see that the contrast layers beautifully in the dependent portion of the thecal sac and finds its way into these very trace little veins that eventually find their way into another vein that goes to the azygos. We have seen other patterns of drainage rather than directly from the neural foramen to the intrasegmental vein. Sometimes the leak can actually go through the epidural plexus, through the bone, and then into the intrasegmental vein. For this reason, if you're treating these, it's very important to close the connections to the epidural venous plexus. These cysts, this is one of those nerve root sleeve diverticulum, a little more prominent, can also have leaks along the posterior aspect into the veins. And in the neck, it's difficult because these nerve roots have fairly prominent nerve root sleeves, but you can see leaks, especially at like T1-2, into these more laterally positioned veins, and these are real. Timing is of the essence, as I mentioned. Here's that same interosseous leak I showed you before. The initial image showed a very clear communication from the thecal sac to the epidural space to the venous plexus of the vertebra to the intrasegmental vein. And just a moment later, you can see that there is probably some leakage into the bone, difficult to discriminate from the normal cortex of the bone, and you do not see the vein later. And this is why we've seen some places will do the puncture and the injection under fluoro and then move the patient to CT for scanning, especially if they have like a photon counting CT scanner. We feel like the sensitivity of that technique is improved because it's a photon counting CT scanner, but the timing is just not right. And so you will miss leaks, and we have seen leaks that were missed with that method. Small leaks can be difficult to detect, and so delayed imaging can be helpful. You can see here that there's like a little curvilinear enhancement emanating from the front of this cyst. On the second scan, you don't see it as well, and we look for those sorts of changes to determine whether or not we think a leak is real. A leak like this we think is real because it has changed. There's an idea that there's some blood flowing through this structure and washing that out. Delayed renal imaging, as I mentioned, super important. Typically, if you inject contrast into the thecal sac, it doesn't show up in the kidneys for quite some time. If there is contrast in the urine, especially around 45 to 60 minutes after intrathecal injection, there is almost certainly a CSF venous fistula somewhere, and you have to find it. The reason we're very strict about maintaining the decubitus position is because as you move the patient, the contrast mixes into the CSF. And what we want to know is there a leak on the side of the patient which is down? If they're right side down, they have not moved, and you see the kidneys at 45 to 60 minutes, it is most likely that there is a leak on the right side of the patient. And that helps guide what you're going to do next. If you do bilateral myelograms, you don't see any clear leaks. You see contrast when the patient was right-sided down and not left-sided down, then you're more likely to look more carefully at the images from the right side or pursue the treatment of things that are borderline or small findings. If on occasion you may see contrast in the kidneys with the patient both sides down if they have a very large obvious leak on one side. And in that case, we still typically target only the one obvious one. If you don't see clear findings and you don't see kidneys, then it may not be that that patient has a CSF venous fistula. This is an example of what that delayed renal imaging looks like. This is contrast not just in the renal pelvis or collecting system, but also in the medullary pyramids. And this is a pretty typical appearance of someone who clearly has contrast excretion in the kidneys. In fact, that earlier case that I showed you, who only had the spot of contrast in that one little vein, very lateral, on 1 myelogram, part of the reason we knew to look back in more detail at those images is because we looked at delayed imaging of her kidneys, and she had renal excretion of contrast. You could even see contrast layering in the bladder. So that was super helpful. So a few pearls that Dr. Orru has put together for us on this topic. You do that lumbar puncture, you do the CT myelograms, and you do this renal phase imaging in the same session on the same machine without moving the patient. We think that that's the most specific and sensitive way to do this. A highly accurate intrathecal access is important. These patients have weak connective tissues. They are very prone to having the meninges separate from one another as you place the needle. And we have seen subdural injections even from what look like perfectly placed needles. So it's really important to place the needle, try and look for CSF return before you inject dye, and to do that test injection to make sure you're in the right spot before you inject the full bolus of contrast. We think that in the cervical and thoracic spine, that the CT myelography is particularly sensitive with respect to DSM because there's less cardiac and respiratory motion. We think multiple time points and multiple breathing strategies are helpful to differentiate artifacts from small leaks. In the interest of time, I'm going to skip forward. I think we've covered most of this. Downfalls of CT myelography, of course, it doesn't have temporal resolution as does DSM. I mean, not in any serious way. It has, temporal resolution on the scale of minutes rather than seconds. The spatial resolution is lower, and the contrast resolution, especially in areas which have limited motion, is a little bit lower. So small leaks can be hard to detect or can be difficult to distinguish from noise. As is true of DSM, probably less so with CTM than DSM. Movement can make the images non-diagnostic. Certainly the dose with CTM can be pretty high. You have to know how to do CT-guided procedures. Those of us who are radiologists should be familiar with that. We think it's faster and better with CT fluoro. As long as your staff is accurately trained, you can probably do this. If you do it with our technique, where everything's done in the room on the table without moving the patient, it takes about 90 minutes of CT time. This is just a review of the diagnostic approach, which we'll skip past here. The key things are identify a site of leakage if there is, and if there's no identifiable site of leakage, then there's probably not something you can treat in a targeted fashion, and that'll affect treatment options later. And I think I'll turn it over to Emanuele here.
Thank you. Thank you.
Emanuele, I will introduce you first. Hi. Thank you for your presentation. Great presentation, Dr. Patel. I think this is the most critical step of diagnosis of CSF-Venous fistula. Now we will follow with Dr. Emanuele Orru. We will talk about management of CSF leaks. Dr. Orru is earned his medical degree and completed his radiology residency at the University of Padua, Italy. He did fellowship training at Johns Hopkins Hospital and University of Toronto. He currently serves as neurointerventionalist at Lahey Hospital and professor of radiology at UMass Lahey. So you can start, Dr. Ru.
Thank you, Layson. Number one, thanks everybody for having us. It's great to see you again, albeit not in person, but we'll work on that when we come down. As Layson said, I want to remark how the portion that Dr. Patel just went through, the diagnosis, is really the critical segment of the whole construction of the management of these patients, because you can be the most effective, the most reliable and the least luck dependent if you have a target, which is a luxury we cannot always have, but we're getting there more and more. So we're getting there, but it's really critical to find in CSF leaks, to find the leak and not to fish in the ocean blindly, but to have a target. So that part was the most important part, because all the other things are parts of the armamentarium that we can be more or less familiar with, but that are adapted to this kind of pathology. So this is just what I said. So we'll go through the various treatment strategies. You will know most of these, except maybe one, or at least maybe not in detail. So we'll go a little bit more on that. And then I will show a few cases to wrap up what has been said. So the first treatment option is to not do anything interventional, which is conservative approach, which can be important for temporizing patients that are present with critical, critical symptoms like coma or other significant, alterations of consciousness or vital function. But in general, these can be temporizing, and in general, they don't work. They don't resolve the problem. They don't resolve the problem. The CSF leaks very rarely, if ever, self-resolve. So these are for symptom relief, temporization, and are essentially putting the patient in bed rest with the head down, abdominal binders, hydration, and caffeine. So you see very simple things, because the problem is very simple. The problem is that there is not enough fluid in the head, so you have to put it back some way. So yes, these are potentially useful options, but obviously you cannot tell a patient, yeah, just live your life in bed. That's not how it works, obviously. So non-targeted epidural blood patch, the one that is often done by anesthesiologists, perhaps without even imaging or minimal imaging guidance, historically has been the mainstay of therapy for intracranial hypotension. It can work when the hypotension is iatrogenic, like post-lumbar puncture or small dural defects post-surgery. But in truth, we don't think that is a valuable tool to definitively cure a leak, because the results are variable. Yes, it can, but it's unclear how. The way this works, obviously, is by creating around the dura an increased pressure, a mass effect that A, pushes more fluid back up, and B, reduces the compliance of the thecal sac, therefore allows it in these patients with the connective tissue diseases to allow for less fluid going in. But again, is a sort of empiric way of treating things, and we try not to use it if we have a target. If we don't have a target, and more importantly, in cases that we consider borderline, we may consider it as a first step before having the patient even undergo all the things that Dr. Patel showed, because the more you do this, the more patients will come without a clear syndrome. And some because they read about it, some because they found it on the internet. And you cannot do myelograms on everybody, because otherwise you would need the myelogram room only for us every day. So in these borderline cases, sometimes we offer a blood patch to see if there is a symptom relief, then we can, and the symptoms come back, then we can do the myelograms. If there's no response, then we know that a CSF leak is not the problem. This is the way it's done, as you know. You go interlaminar, hit the epidural, obviously not trying to not violate the dura, and inject autologous blood. Usually, in operators that do it blindly, they say, well, put as much as you can until the patient feels back pain. And we kind of do like this, but we have seen that as much as you can is about usually 10, 15 cc's. Now, we do a higher tier of this when we do high volume epidural blood patch. That usually is what we do in cases when we do blood patches. I think Layson saw one of these. So basically, we go in CT, we puncture at the thoracic level, high thoracic like T1, T2, T3, then low thoracic T11, 12, lumbar L4, L5. Obviously, we confirm that we are epidural with a small injection of air. I will show you the technique now. And then again, we do a regular blood patch at 3 levels, and this makes it become a high volume blood patch. And this has shown to provide a lot of symptom relief and to be more durable. Then we provide the patients with specific instructions. Remember, these are patients without a target. We don't know where they're leaking. Sometimes we don't know if they are leaking. So we give them instruction on activities to do, positions to do. They're quite strict, and I'll be happy to share them. And then we monitor the clinical course to determine the next steps. If this is done for semi-diagnostic purposes, if the patient does well and the symptoms come back, then, we validate the fact that there's a CSF problem, and then we can go towards the myelograms and all that. I had a patient which had a syndrome that was borderline. We didn't know, we did this. She had zero improvement. And this, if you have a low CSF, should bring improvement. So the fact she had zero improvement made us understand that there's no reason of doing myelograms in her. So that's a useful thing, can be a useful tool. So this is how we approach. This is a T9, T10. Actually, you can see this is a patient that had a prior embolization here. This is onyx, which didn't work. And then we did this and didn't work. So we completely excluded the CSF, CSF disease. So you see, we access the epidural space. We confirm with some air that we are in the epidural space and not intrathecal. And then we inject blood with a little bit of contrast. And here you can see beautifully the displacement contralateral of the thecal sac. And this really creates a pressure around the thecal sac that pushes fluid up and blocks fluid from distributing around the cord. Then there is the targeted blood patching. This plus or minus fibrin glue injection. This aims at compression and scarification of the dural root diverticula, which usually harbor the leaks and the fistula, but sometimes you can't see the fistula. And then you say, okay, let's target the diverticula. You do multiple level blood patching under CT, and hope that this will create a scarification around the diverticulum, that if there is a fistula in a patient that is suggestive, will cure it. We have cured a patient like this. Others have returned. Is very unreliable. But it's a good tool. For example, if you do a myelogram and if you see 20 things that seem a small leak, maybe it's all noise and not signal. Maybe there's nothing. Well, before doing 20 embolizations, which is a long thing, you can do this and see if it works. So this is the way you do it. Under CT, transforaminal approach, inject some contrast to check that you're in the right place, and then inject blood. And you see that it displaced the thecal sac laterally and that the contrast has been displaced around the blood. So you know that you have done, a successful one. And you see, by the way, that the cyst here has been compressed. Endovascular technique, the hot kid on the block, the new kid on the block. They seal the CSF-Venous fistula from the venous side. They need a specific target. Do not do it without a definitive diagnosis. Once you see a CSF venous fistula, you catheterize the draining vein at the level of the leak that you saw on the myelogram. That's why it's so important to do a high quality myelogram. And then inject liquid embolic. For now, it's onyx. I don't know, maybe in Brazil you have squid or fill, but these are all fine to use. In Europe, I know they use squid a lot now, so and we will probably when it comes. When the fistula is seen, the results are really excellent with more than 90% efficacy. You need to know venous anatomy. You need to be familiar or to become familiar with catheterization of the azygos vein and with more complex catheterization of vertebral artery plexi, of sort of supreme intercostal veins and other less traveled venous outflow. This is a classic example. This is the intersegmental vein. This is the desired distribution of the liquid embolic, should go in the epidural space, very important, should close almost all the egresses for the fistula. And this is a classic case here when we have a simple to reach level. We use a dual lumen balloon. This is an eclipse. And then we inject from the balloon. And you see that the liquid embolic here distributed in the subcostal vein, in the periforaminal veins, and you can see a casting of the cyst in the posterior element vein, and it distributed to the epidural plexus. This is I don't like the word, but ideal embolization. I was almost saying perfect, but this is an ideal embolization because you have closed all egresses and reached the epidural, which we have found to be critical. This is more complicated. Right T1, T2, you have to travel through the epidural plexus from the vertebral plexus, can be complex. Fortunately, these maneuvers are not very dangerous, so you can do multiple trial and errors, but these navigations are more difficult. And this is an example on the same patient on the other side. Here, we couldn't even see the vertebral plexus, so we had to travel somewhere, inject onyx, and wait for the onyx to go, to distribute epidurally. Major complication rate, 0. In other words, stroke, death, significant morbidity. This is reassuring. Probably, in theory, this is less dangerous than a diagnostic angiography. Minor complication, postoperative pain, 3%. Maybe that's a mistake. I should have added a 0 because almost 30% of patients have back pain, but that goes away. PEs have been reported. We've had 2. They're not a problem. Small amounts of onyx go in the lungs. Venous perforation we haven't had, but it has been reported and it's very benign. Follow-up, you can see if you do a targeted embolization, almost all symptoms have a 70 to 80% likelihood of resolving. And if not, around 90, give or take, of improving. Less so the personality ones, but these are very rare. Then there is surgery. Surgery is very important and is the mainstay of therapy for certain leaks. 1A, the bone spur that perforates the dura. This is a surgical case. 1B, the lateral leak from the dura in an epidural fashion. Extrathecal duroplasty, another time in which the surgery is the way to go. Diverticular clipping for leaking diverticulums. This is an option. It's very rare. Dr. Pace, our partner, has one coming, a ruptured diverticulum that he has to leak. And disconnection of the fistula with ligation of the veins. This works very well. We have never done one because, the transvenous embolization works great and you don't have to do a foraminotomy and all that. But in some centers, like in Los Angeles, they only do this. So this works. It's institutional. I think endovascular is better because it's less invasive. But, and that I think is the general sentiment. But there's also this option. One last thing, rebound intracranial hypertension is common. This happens because especially in people that have had this for a long time, they are used to a chronic state of CSF depletion and low pressure. So once you close it, the immediate repletion of CSF can cause actually intracranial hypertension. And this is most often in women with calvarial hyperestosis. Maybe there's less room for accommodation and long duration of symptoms. One out of 5 of these patients will require Diamox, and it can be a very complex management. And sometimes, rarely, we start them on Diamox directly, but now we usually send them home with Diamox, and we tell them to contact us if they develop intracranial hypertension. And the symptoms are very clear, because the symptoms are usually the opposite of what they had before. They want to stand up. They don't want to lay down. So this is usually fairly clear to understand. In some cases may require shunting, even transverse sinus stenting. Recurrences may happen 7% at the site of treatment. They may not be recurrences, they may be residuals, and 10% at remote sites. We have seen that happening 3 times in a patient, springing new fistula after new fistula. And this is when patients have multiple diverticula, long symptom duration. Maybe rebound intracranial hypertension creates a hypertension that patients with weak collagen cannot actually compensate with just compliance of the dura, and then they develop new fistula. We don't know exactly why this happens, but almost certainly there is a genetic component. So I'll very briefly show you 3 difficult cases, because I want to show you that each step can be difficult. So here we're talking about difficult diagnosis. So you see here patient with classic signs of intracranial hypotension, multiple cysts, should be a slam dunk. Well, it's not. We do bilateral myelograms, we find nothing. We do transforaminal blood patches at the level of the cysts, and she has immediate relief, but transient. 1 month later, she comes back. We do multiple DSMs. We do DSMs. We can't find anything, only this small thing, but there's no lateral escape of contrast. She gets another round of blood patch, and has again only transient, relief. This is what we found on the DSMs, but that doesn't go in veins, so we don't think much about it. Since the last procedure, she becomes drowsy, progresses to coma, and essentially requires ICU admission. She undergoes the conservative measures I told you to temporize her while we understand what to do, and importantly, to keep her alive. So now we repeat myelographic imaging, but with delayed acquisition for the renal collecting system. And you see that on the lateral decubitus, the kidneys don't light up, so we can exclude a fistula on this side. And on the right lateral decubitus, this was the left, on the right lateral decubitus, there's florid kidney excretion. So we do a second review of the right-sided myelogram, and we see what Dr. Patel showed. This, in thousands of images, only this contrast in what seems to be a subcostal vein is the only thing we can find. And in retrospect, is this? And in retrospect, there is a dot here. This is how subtle it can be. At that point, we had no option to try to treat this patient. She was dying. Like, in other words, if she was not in bed with the head down, she would actively die. So we go in the T11 intersegmental vein, and we do what I showed you before, epidural, peridiverticular, all the egresses are closed, and she's cured. Immediate relief of the symptoms, discharged shortly thereafter without ever coming back for a headache. And she was very grateful. She feels that you saved her life. These patients are enormously grateful. They will, the neurologist will send more patients to you if you do these things. And this case went on TV. This is the patient, this is the reporter. They came to interview us. And if you scan the QR code, you can find the whole reportage and the video section. So the bottom line is that renal excretion confirmation can be critical and may prompt a re-review of the images or repetition of the exams. The findings can be subtle. CTM doesn't have the temporal resolution, so you need to do multiple scans. And unfortunately, confirmation may come only after embolization. In other words, we didn't know that we were on the right track. It looked like we were, but we knew only after. Now, this is a post-onyx recurrence. You see, we had already embolized, and then there is this recurrence near the onyx, and with a transosseous drainage. And you can see how difficult it is to see the contrast when you have the noise from the onyx. So it's very useful in CT to do a mask when you redo it. So you have a mask, you have a cast of the onyx, and then you can basically subtract the new contrast. It's much more difficult in DSM, for example. Now we go from difficult diagnosis to difficult treatment. This is a patient with obvious hypotension, and he had fistula at right T1, T2, and left T1, T2. These are the most difficult places to reach. And you have to study the anatomy, in particular these unusual pathways. There is this article by the Mayo Group, Borg and Bring Gigi. This is all you need to know. Read this article, print it, study it, consult it every time. This is really all you need to know in terms of anatomical navigation. And these are the cases I showed you before. Here we had to go in the epidural through the vertebral plexus from one level up to down. And on the other side, we had to navigate a very complex network of vessels until we thought we reached the epidural plexus, and then we could, wait for the onyx to help us a little bit and diffuse more distal than our catheter was. So high thoracic fistula may require unusual catheterization, and anatomical routes should be reviewed prior to the intervention. We recommend for complex anatomies to do a CTV before. We have a very low threshold for ordering images. This is another difficult treatment. Again, classic signs of hypertension, lots of diverticula. But as I showed you before, the patient, which is the same that I showed you for difficult diagnosis, had already multiple embolizations. So now we have the new leak, the one that I showed you. How do we reach that? Because we have closed all the veins. Well, and as you can see, they were closed very well. Well, how do we do? We travel through the epidural plexus, which is a highway with a lot of exits. We wanted to get here, so it's from the contralateral down and up. And this is what you see when you inject in the epidural plexus. And we did this beautiful epidural embolization, which resolved for some time the patient's symptoms. So remember, you can navigate the epidural plexus when you cannot reach something or you have already embolized away and there is a recurrence in the same level. Now let's talk about difficult post-procedural management. This is a beautiful fistula. You see it clearly going in the azygos. It's amazing when you see these things. And we treated it very nicely, beautiful. As I said, all egresses closed, peridiverticular casting, epidural casting, but she developed significant rebound intracranial hypertension. So bad that we have to bring her in for a high volume tap. We start her on Diamox, the symptoms return. She has repeat admissions, undergoes multiple LPs. We increase Diamox. There are multiple types of formulations. We found that the extended release works best. Ultimately, her hypertension resolved and now only has mild hypotensive symptoms, much better than she was in the beginning. But she, even when she was weaned off Diamox, she maintained sort of a state of mild hypotension. So these patients may have a very poor autoregulation of the pressure. They may require readmission, multiple procedure, complex management, and this is the part that we know the least. This is the least understood part in terms of standardization. Last case, difficult post-procedural management. This is a patient that underwent multiple embolization, had intracranial hypertension rebound. After 6 weeks, so was cured with a high volume tap. After 6 weeks, have a recurrence of the symptoms, 2 new fistulae, second embolization, 6 weeks post-op, she was weaned of Diamox. But then she developed again rebound hypertension, and then intracranial hypotension again. And then we found 2 new fistulae. Then we did a third embolization, we pre-medicated. Then we kept her on Diamox for months and weaned her off slowly. And now she's in a state that alternates between hyper and hypo symptoms without real resolution. The patient is very frustrated. We do not really know what to do next. She saw multiple other doctors and they're all puzzled and they all can't find another solution. And by the way, this is the same patient that I showed you multiple times. So this was a difficult diagnosis, a difficult treatment, and a difficult postoperative management. So the take-home message here is cases can be difficult at all stages, recurrences are possible, and we are still in the learning process. So before we wrap up, unanswered question, what causes these things? We don't know, probably some collagenic disease at the base, but why some people develop it and some don't, we don't know. Is there a normal amount of leakage present in everybody? With CT, we are quote unquote so good that we may see too much. Do we close too much sometimes when we see all these small fistulae? UCSD has demonstrated that there is an amount of physiologic leakage. How to predict who will develop hypertension after a treatment? That we really want to know, and we don't understand that. And in general, how do spinal compliance, venous outflow, glymphatic drainage interact with spinal CSF dynamics? This is still unclear. Obviously, awareness about the disease is critical for doctors, for providers to refer to the appropriate center. MRI of the brain, MRI of the spine, and dynamic decubitus studies in the fashion that Dr. Patel showed are the best way that for now we have to identify these pathologies. Most often they are epidural collection from dural tears, CSF-Venous fistula, least often leak in the verticulum. The most critical message, if you can, meaning if it's possible, find the leak, identify the site, because that will lead to the targeted treatment. Because otherwise they won't be effective, or you'll be relying on luck. And we want to minimize the reliance on luck that we give to our patients. And complex patients, the more you will treat, the more you'll have complex patients, may require multiple treatments, may require empiric treatments, and you are still in the infancy of this, so it's still unclear the right treatment for every patient. In the future, hopefully, we will have a less empiric way to manage some of these syndromes. And we just remember, if you think all of this is super complicated, is a loss of time and all that, CSF leaks are great practice building elements. Patients will come in large amounts, not only with this, but the referring physicians, once you cure one of these patients, they will send you everything, aneurysms, AVMs, all that stuff. So it's an investment even for the practice. This is the group. This is the only one that you have not met today. Jonathan Pace, our neurosurgeon, and the other three, obviously, you have come to know today. And for whoever wants to take a small trip, but for a very, very good reason, we are hosting a very high level, intervention and neuroradiology symposium with faculty from all over the North America, and not only, but mostly from the New England, Boston area. So we're talking about us, Harvard faculty, Tufts faculty, Boston Medical Center faculty, so all top level universities. And in 2 days, we will really, I think, make the point on the current status of neurointervention with a lot of emphasis on new things like what you have heard today, obviously, complex things like brain-computer interface and all that. So everybody is welcome, more than welcome to Boston, and is a great season to be here because we are going in the fall, and so there is the foliage, so the beautiful autumn colors. And thank you very much. Obviously, follow us on all our social media and email us with any question.
Thank you for the presentation, great presentation, Dr. Orru. I had the opportunity to observe all the steps of about diagnosis and treatment of CSF-Venous fistulas, the appointments, the CTMs, embos, post-ops, and follow-up too. So I know how this treatment is life-changing. Now I will open to discussion. Dr. Leonardo, you can start if you have one question. Is in mute.
So how about September 3rd?
Sorry, I always forget about this. But first of all, I would like to thank you guys for this. This lecture was amazing. You guys covered everything. Actually, you didn't, leave space for us to make any questions because you answered them already. But, actually, I would like also to introduce my right hand here, my associate, Dr. Oliveira Livia. She's been with me for like 13 years now. And we had to hold the patient here for like more 30 minutes because we didn't want to miss this. But I still have a question, which is we always want to avoid invasive procedures, like especially diagnostic invasive procedures. So I would like to ask you guys if there is a group of patients, and which one would be, that you go ahead and you do the treatment without doing the CT myelogram, just based on MRI findings. Is that possible? Or you always have to make sure with the CT myelogram or DSM that there is really a CSF-Venous fistula?
I think that you won't be able to identify a target for treatment without the myelogram for embolization. SLEC patients, if you, as I said, if you can see the collection of epidural fluid and you can see the bony spicule that might have caused the tear, that patient can go to surgery without invasive imaging if there's a sufficient confidence. But to get the confidence you need to find the fistula without a myelogram, I think is very difficult because most of these patients have multiple diverticula. The location of the leak is not always correlated with the size or irregularity of the diverticula. And to do embolization at the levels of all diverticula is not necessarily feasible.
Okay, thank you. And the other question is, in your series, we saw here that you have like a bunch of patients that even after the embolization of the CSF fistula, the CSF-Venous fistula, they still keep symptomatic. What would be the reason for that? I mean, is there anything that you're missing, or is there any kind of, internal hemodynamic or, CSF dynamics process that wouldn't let the patient to I would say to get back to its normal pressure?
Well, so we have not had very many, in fact, none with a clear fistula that remained symptomatic after the fistula. So they may have developed hypertension, which is different thing. Actually, it's a sign of success. It's an aberration of success because now you have another problem. We have had patients who underwent treatment of findings that were subtle and equivocal for a fistula, but that were the best thing that we had, and that did not get relief. That may mean that they were just not fistula, or because the accuracy of these myelographic techniques is not 100%. You can have false positives, and that we have had recurrences, but I don't recall a patient with a clear fistula which we targeted, which did not have at least temporary symptom relief. They may have had a recurrence or a new one, and that's a different story. But in general, when you target correctly, is very rare. Or the other option that there can be, this has not happened to us, is that there is another fistula, because we have experienced a lot of patients that had one big and one smaller, and we have to treat both. So it's possible that one was missed.
Okay, all right.
Dr. Krings, as you said, we have many patients with difficult clinical findings. So what do you recommend to the neurologists? We have neurologists in the team and other neurologists watching the presentation. What do you recommend to identify better the patients with SIH and refer to interventional neuroradiologists?
I think that's an excellent question. I believe that the most important component is to think about this disease, to keep it in your differential diagnosis. It's from a clinical perspective a chameleon. It can look like anything. There's no symptom that cannot be present in patients with SIH. Unfortunately, it is not in every patient like as classical with the orthostatic headaches, and therefore it may be overlooked. And I think the important component is to just keep it in mind as your differential diagnosis. And also ensure that your radiologists are aware of these findings that Dr. Patel presented, as sometimes the imaging findings are also misinterpreted as pachymeningitis, as chronic subdural hematomas. We had one patient who was treated with bilateral CSDH embolization, where in fact he had spontaneous intracranial hypotension. So it's just important to think about the disease.
Okay, thank you. Dr. Yoshimura and Dr. Fabrizio, if you have one question, and we have other people from Rio de Janeiro too.
Yes. My name is Kim, and I'm calling from Dr. Fistula.
I think I have another question to Dr. Patel. Just to summarize, when we have let's say non-venous fistula CSF leaks, do you recommend to do conventional CTM first?
Or
Yeah. If we think that there's a collection of fluid in the epidural space, conventional CTM is what we recommend.
Okay. Thank you.
That confirms first off that the fluid is in fact CSF, because the myelogram should show that the contrast goes into that collection. Second off, if it's a ventral collection, which most of them are, it can identify the bone spurs that can cause them and can sometimes show you the dural defect. For lateral leaks, sometimes it can actually show you the dural defect, and those tend to be a little more confined, so you more or less know what level they're at, and you can see them quite reliably.
Okay. Thank you.
So I think for anything that looks like there's a collection on the MRI in the epidural space, a conventional CTM is the first move.
Okay. Dr. Fabrizio.
Lyson, just thank you for excellent presentation. I don't have any questions.
Okay. Dr. Fabrizio is interventional neuroradiologist in Campinas too. So I think
Actually, Lyson, I just came up to me another doubt here, because I think Dr. Orru said that it's very hard to predict those patients that will develop venous or intracranial hypertension after the treatment, right? So would it be useful to do or to check the transverse sigmoid sinus morphology beforehand? So in case I know that it won't make a difference in terms of indicating the treatment if the patient has the CSF-Venous Fistula, but at least you know beforehand that if this patient is at risk of developing a post-treatment hypertension.
I think it's an interesting idea. We have not routinely looked at the sinuses and that before. If we think that the sinus is stenosed because of an increase in pressure, because the sinuses, it's still unclear why the sinus is, narrow in people with IAH, no? And we don't know if the sinuses create the IAH or vice versa, or it's an interconnected thing. It has been reported. We have not had the case, for example, but at the Mayo Clinic, they had to do some transverse sinus stenting from severe rebound intracranial hypertension. So I mean, I don't know, because I really don't know, but I think it's since we have MRIs for these people, would be interesting to see if in patients that develop intracranial hypertension after there was a pre-existing narrowing of the sinuses. At least maybe not to do anything primarily because we don't know, but I think it's a good idea to see if that can be considered a predisposing factor. What do you think, Dr. Krings, of this?
It's a good point, and I think it just showcases that we are here with this disease, just really, as you multiple times said, Emanuele, that we are just at the infancy of starting to understand it, and there's a lot of research that we'll need to still do. A very interesting finding that we could also think about from an imaging perspective would be DTI-ALPS, i.e., looking at glymphatics or surrogate parameter of glymphatics. As in intracranial hypertension, we will have different glymphatics as in hypotension. And maybe this is one of the research projects that we will be doing here at Lahey. Looking at these patients pre and post and finding out parameters to like which constitutes hypotension, which constitutes hypertension may be really helpful. And one of them could be indeed looking at the transverse sinuses. So it's definitely an interesting feature to look at.
My last question about the treatment, Emanuele. I remember in all cases I saw you used Onyx, but in Brazil we have two different realities in public and private system. So my question is possible to treat effectively CSF-Venous fistula with glue, for example, with a cheaper glue, for example, Hypotension or Glubran?
Yeah, I don't think so because glue is adhesive. It's not cohesive. So as soon as it touches blood, it thromboses everything, and these can be very long injections. And for glue to not reflux and close your way, you need to be wedged. So I don't think that is a liquid embolic that lends itself well to a network, to almost like you don't want to be wedged basically in this. You want to be less selective in a way. You want to be in the right place, but not so much in one place. You want to have the possibility for the onyx to distribute so much. Many of these injections that you saw, almost all of them, were intermittent, as you remember, are the result of intermittent injections over a long period of time. And the onyx has to diffuse in some parts to sort of create gradient pressures, okay, to go in other parts. And sometimes you get to the place you want after 5-10 minutes sometimes. And with glue, we have never tried. I don't think anyone has because of this. You could thrombose a portion, create a cast of thrombus around the catheter, then have reflux, and then you have closed the way and not reached where you wanted to reach, because this you need to push. So that's why you need a cohesive, like this famous lava-like thing, but really a cohesive agent to create, to go with the gradients that you create and not just create a localized thrombosis. That's what I think.
It's a retrograde pressure cooker technique, and retrograde pressure cooker, unfortunately, for the time being, just onyx, fill or squid.
Thank you. So, do we have another question? I think we can finish the meeting. So I would like to thank you again for the presentations, and Dr. Krings, Dr. Patel, and Dr. Orru. All of you, I'm thankful for the moment in Lahey Hostel, and now to share your knowledge and experience with this disease. So I think we can do more meetings in the future. So it's a pleasure to see you again.
All right, I endorse that.
Anytime.
Thank you.
Thank you.
Thank you very much, guys. You've been great. Thank you.
Thank you. Bye-bye.
Bye.
Bye-bye. Thanks.
Let me